My name is Sarah Hersey. I am the Director of Collaborative Intelligence in the WHO Health Emergencies Programme, and I'm based here in the Pandemic and Epidemic Hub in Berlin. And today, we have a really interesting session on advancing trust for emergency preparedness and response and discussing what needs to be done. So the WHO Health Emergencies Programme is hosting this in this global health lab. And this is, I think you can all tell, a slightly new forum and design for how we have these conversations. We've had a lot of big plenaries that don't really allow for audience participation. So this is an experiment this year, so thank you for being our guinea pigs. And it's really to help foster our interactive, in-depth, and open conversation. We want this to be both a moderated conversation and a conversation with the audience. And also, we will not be live streaming it, but it will be recorded. So there will be an opportunity for greater distribution later, but right now this is a closed audience in the conversation. We have a very diverse group of speakers with us today, and they bring in a lot of context, as well as, very importantly, their firsthand experience in this work. So we're going to begin with a scene setting discussion from the Global Listening Project, and then we're going to go into two fireside chats. And the first one is going to be with our colleagues talking about community building and community trust. And then the second one is going to be around trust with policymakers. So these are integrated conversations, but we're bringing two different audiences to approach them possibly in two different ways, perhaps in the same way, we'll see. And we know that these, they're interrelated, and they're incredibly important, both for preparing for the future, but also in addressing trust for the public health emergencies that we have right now. We also have a very diverse audience, and I want to thank you for coming, especially for those who applied on time so that we could get you your ticket. We know it was a little bit of an unusual format, but we have colleagues from ministries of health, we have national public health agencies, we've got civil society with us in the room, we have academia, donors, we have private sector, we have youth and women's groups, and many others. So really want to thank you for coming and for your interest. I just wanted to say a couple of notes. Many of you might have joined we had a plenary session on trust building with public health emergencies yesterday. It was one of the first sessions of the conference, and it was focused on the regional approach. And I just wanted to pull out a couple of themes to lead us into this conversation today. And one of the biggest ones was that the mutual trust really needs to be built between the public as well as the politicians. And right now we're bringing the public together with the politicians, so I think we're a little bit ahead of the game. It's even more critical now because the trust from the community significantly deteriorated in a lot of places during COVID-19. And Minister Lauterbach really pointed out something that we're at a tipping point. We have a lot of emergencies right now, as well as climate change and conflict are putting even more strain both on our populations as well as on our public health systems. And we're also seeing the erosion of trust in science. And as we see the erosion of trust in science, we're seeing the erosion of trust in public health. So with that, we are going to be exploring some of the key factors today that influence the public's confidence in our government and institutions, as well as what do we need to do at both the policymaking and the community levels to both restore and enhance public trust for better emergency preparedness and response. So now I would like to invite Dr. Heidi Larson, or Professor Heidi Larson, who is going to give us a scene setting. She is the chair of the Global Listening Project, and she will share her insights on building public trust for emergency preparedness. She's an anthropologist and the director of the Vaccine Confidence Project and a professor at the London School of Hygiene and Tropical Medicine. She previously headed the Global Immunization Communication at UNICEF, chaired Gavi's Advocacy Task Force, and served on the WHO's SAGE Working Group on Vaccine Hesitancy. And we are very excited to have her. So over to you, Heidi. Thank you.
Thanks very much, and sorry for those of you. I know these chairs turn. I was in a session here yesterday, but sorry for those who end up in the back. I'll do my best. I was in a session in this format yesterday. It was really good, and we had a lot of interaction. But yesterday was about trust in the context of promoting health more broadly and getting people on board with different interventions and different approaches. But today's different. When we talk about advancing trust for emergency preparedness and response, it's a very different issue. We need it even more, but we can't necessarily build it in the emergency. I'm not one to say you can't build trust in an emergency. I think you can, but I wouldn't count on it. You really need to be building your trust in as we call this, peace times, although they don't feel very peaceful, but before the next bigger, particularly health crisis hits. But as we learned in COVID and in multiple other emergencies, Ebola, which my colleague Mohamed Jallo, we worked together on in Sierra Leone, emergencies are constantly changing. So one of the biggest things that we need to anticipate is the deeper your trust is, the more you're willing to tolerate a certain level of risk. We did a 70-country study in the Global Listening Project, which is an initiative that I launched in 2021 after nearly 15 years of having founded and led the Vaccine Confidence Project. We learned a lot about trust. And I would say about 60% of the time, trust and confidence issues were not about the product. And that was a big learning. It was about the institutions that make them, deliver them, regulate them. It was about the local health services. It was about historic issues. It was about community memories. It was about a lot of things that we learned had a lot of relevance to not just vaccines, but multiple other health interventions. So the 70-country study we did, we rolled it out last year, and we're in the process of wading through all the data, which is all accessible by country on the Global Listening Project website. We did a lot of trust mapping, and really what I think is super important is we cannot think of trust in a bilateral way, trust in a product or trust in different things. We need to think of the ecosystem of trust. Trust is, and Mike Ryan mentioned this yesterday, and it's written in a lot of the literature, trust is not a thing. Trust is about a relationship. It's dynamic, it's changing, it has good days and bad days. You think you built it and then you lose it. It takes a while to build, but it can be built more quickly. And I think one of our challenges with post-COVID recovery is that we don't lose and we document and try to build on the local trust that was built during COVID, because we see that those who had the highest trust in the government response had the highest willingness to accept vaccines, even under emergency preparedness. They were the most willing to cooperate. And so there's a strong relationship there. But in another session I was in yesterday, the point was raised. This was a colleague from Brazil, and I'm American, so one thing we had in common was not particularly trustworthy leaders at the time, and who do you turn to? So there are situations where institutions or leaders are not particularly trustworthy, who are leading you away from the science. And then we need to think of, well, in this ecosystem of trust, where do we build it? And in a lot of cases, local. Community leaders mattered more than ever. People met people in their community that they didn't even know. They lived in a city, and it's the first time they met their neighbor, because they usually went straight down the elevator or wherever to work, and it changed dynamics in communities during COVID. So we need to look in other places, and sometimes it, like in Portugal, did very well in Europe in COVID and certainly in vaccine uptake. But people told me there, well, we don't really trust the government, but the military came in and they did it and we trust them. So it might even be a national entity, not just a local one, but one that they feel is more trustworthy. So we need to keep our eyes and ears out. And frankly, now is the time to do some trust mapping in your own countries, in your own situations, and see, okay, who were the ones that built trust during COVID, and let's build on that. And then who are others that we didn't? And we have to, each emergency, each crisis is going to have different dynamics. It happened to be older people that had the highest levels of serious illness and death during COVID. But if we have H1N1 or H5N1 or an influenza 1, it may very well be the young people who felt like they were paying the price for their education, their social life, whatever, for what they perceived as an older person's problem during COVID. Well, next time, they might be the one. So we've lost a lot of trust with them. All of our research shows 18 to 24-year-olds are coming out of COVID not happy campers. I mean, it was already wobbly because of social media issues, but that's something that we have to be vigilant understanding. Trust is we're going to hear about this from some of the panelists. You need to continually nurture it. I think everybody knows that. And I think we have a lot of more panelists than the session I was in yesterday, so I want to give them their main stage today. And we luckily have different sectors. The last thing I want to say is in the Global Listening Project, we're developing what we're calling a societal preparedness index based on these 71,000 people we interviewed and had focus groups with around the world. And the three pillars that we saw emerge in terms of our trust framework was willingness to cooperate is key. Capacity to organize, okay, we're willing to cooperate, but as a society, as a community, do we have the capacity to organize? And third, the ability to cope, individual ability to cope. From 71,000 people that we surveyed and interviewed around the world, the highest numbers came out with individuals feeling like they have an ability to cope. The numbers went down with capacity to organize, although that was higher. Where it really fell to the bottom was people's perceptions of how government's readiness and capacity to lead an emergency. And my last point is that one of the things we learned is because in this survey we asked people to assess how well their government did, and we learned that how they assessed their government had nothing to do with case count and death count. It was all about, did the government take into account my well-being, my kids' schooling, our livelihood, our jobs, our future, food security. That was a big one that came up in Africa. Their biggest concerns were not about the number of cases that were circulating, which is what they kept hearing on TV. Flatten the line, get your jab. They wanted to know, I'll get that jab if you help me out and make sure my kids don't come out of this, struggling in school or with, we have in Latin America, more of the issues were about domestic violence that came up. In New York, it was mental health, and countries in Africa, we heard, particularly in Nigeria, food security. None of them said their top concern was COVID. They were worried about all the fallout. So if we pay attention to that and that recovery now, we'll be building trust for the next round.
Great. I just want to thank you for setting the scene. I think a couple of the very important points is also noting what trust is not. And I like the idea of it not being a product, but more being an issue of leadership, of institutions, of systems, of community building, and it not being a thing, but it really being about relationships. So I think that's a great way of framing the next two fireside chats. So we're going to invite the first group, where we're going to be discussing community engagement. If I can invite up Dr. Nedret Emerooglu, who will be sharing her perspectives as well as moderating the session. And Nedret is the Director of Country Readiness Strengthening in the WHO Health Emergencies Department, or Health Emergencies Programme in Geneva. She's a public health leader who played a key role in eradicating polio in Turkey and led vaccination efforts at WHO across multiple regions. And she's also held many leadership roles with WHO Euro, including Director of Program Management, leading the immunization program, and contributing to the region becoming malaria-free. So thank you very much, Nedret. And if I can introduce our other speakers. First, Lisa Hollins, who is the Executive Director of UK Operations at the British Red Cross, leading vital services such as refugee support, crisis response, and health partnerships. She has 29 years of experience with the UK National Health Service and has held leadership roles in accidents, emergencies, mental health, and major trauma services. So welcome, Lisa. And last but certainly not least, Mohamed Jallow, if you could join us. Mohamed is the founder and CEO of Focus 1000. It's a leading NGO in Sierra Leone focused on improving opportunities for vulnerable children and families by transforming social and traditional norms. And Mohammed has 50 years of experience, and I have to repeat that, 50. And the last time I introduced him, people said 15, and I said, oh no, 50, he's just got really good skin. And I have to say, I feel like I'm an old family friend now of 3 generations of Mohammed's family. He has worked for 13 years with the government of Sierra Leone, 25 with UNICEF, both at the national and international levels, as well as 12 years with Focus 1000, focusing on smallpox and polio, Ebola and COVID, and particularly in developing strategies to engage religious leaders and traditional healers. So thank you all. Over to you, Nidrit.
Yeah, good morning, and thank you very much, Sarah. And following up the excellent introduction by Heidi, now we will try to focus on the community-centered actions. And I will have 2 wonderful panelists that we will try to dig in, and I welcome you all to the session. But also, we would like this to be an interactive session, so we'll try to keep some time at the end to be able to get your comments, experiences, questions into it. So let me try to start with framing what we mean by building trust within the communities. This is actually as part of a critical element, putting the communities at the center, not during emergencies, but also during the peacetime, in delivering the normal interventions for prevention or health care, and also using those networks and capacities to be able to be prepared and create a community which is ready and resilient for any coming health threat. And we have seen many examples in the past. We have gone through SARS, H1N1, Ebola. Of course, the biggest eye-opener was COVID. And within COVID, the different communities acted differently. We tried to find the reasons for certain communities either rejecting some of the national policies or not accepting the vaccination, as we have heard from Heidi, and many of the interventions were taking different impact within different communities. So building that trust and building a platform, the structure, the institutional preparedness for being ready for any health threat is the critical element. And I would like to remind you the recent concept note that WHO published, which is defining the community protection in close collaboration with UNICEF and IFRC, and I would like to take them for their input, trying to identify what could be the strategies, tools and methods and networks to be built upon. And it, of course, requires all of us to be engaged fully. It is a full partnership. It is engaging the communities in and involving the communities and empowering the communities. So it's not only risk communication and telling the accurate information to the community and expect them to follow your instructions, but looking into what their needs are, because it is very context specific, and we know that localized action matters, and from the communities it needs to go up to the regional, national levels to be able to have the interventions in place. And within the partnership, we each have a role, and I'd like to emphasize a brilliant initiative between WHO and IFRC, the collective services, which had started during COVID and continuing to engage into many of the current responses. And that's one of the models that we try to look into, how to bring consistency in the policies, consistency in the messages from different players, and then how we could engage the community level leaders, the governance, taking a whole of government and whole of society approach, and being able to mobilize those resources for effective interventions, either medical countermeasures or public health and social measures to be implemented. And within that, trust is critical, and which is a complex issue that we will look into some of the examples. It requires many, many investments in advance, and it has to be engaging the local leaders, the context of the community, considering their unique needs and experiences, and being a process which is co-lead with the decision-making and implementation, engaging all different stakeholders in the community. The role of civil society, the workforce, community-based workforce, and also looking into the service delivery side is critically important before and during the emergencies. How to build that public health functions needed to be able to early detect any threat which could turn into an emergency, and at the same time how to build that systems which is linked to the country's health system, starting with the primary health care. So there is a lot to be done, but what is critical is us to join in a broader partnership and working hand in hand to be able to support the communities to be ready and resilient during and after a crisis. So let me conclude here the introductory remarks, and I would like to now ask Heidi, who has a broad experience within her work with the UK operations with the British Red Cross. So, Heidi, what do you think the community-centered approaches should be, and what could be prioritized to ensure the communities are included in the decision-making process for preparedness and response to health emergencies? Can you share a few examples, which I know you have many innovative solutions that you have gone through?
Thank you. I'm Lisa Hollins. I'm the Executive Director of British Red Cross. So I will share some examples, but I'll start from lessons learned and just make sure that we start with some of the biggest things that we need to change and really focusing on those areas. So I think firstly, during the pandemic and we've had a huge range of major incidents, we have learned a whole range of things which has meant that we don't respond that's okay. We don't respond in the best way. And certainly during the pandemic, I was a national director for our health service, and some of the big lessons were twofold. The first one is that people respond are impacted differently during the pandemic. I think we all saw that. We saw that if you were members of certain communities, you were impacted more. If you were a member of poorer communities in the UK, you were impacted more. If you lived in a household with a multi-generational living, you were impacted more. So there's all sorts of inherent risks that people face that were not equal. And that has driven different levels of impact for COVID and will lead different levels of impact for other emergencies. And one of the biggest indicators in the UK, and I'm sure this is similar across the world, one of the biggest impact indicators of whether you will succeed in responding to a crisis, whether you've got the resilience to bounce back, is how much money is in your bank account. If you have less than £1,000 in your bank account, you have far less choices. And when we talk about resilience, we need to be really clear about what's the drivers of resilience, and if there are inherent risks to certain communities and certain people, we should make sure that whatever response we're having at local and national level, that needs to accommodate that. And there will be people through all sorts of, who have all sorts of different risks that we need to support and help. So that's some of our lessons learned. And then in terms of some of the innovative approaches, spent many years being part of the government and delivering healthcare, but I'm on the other side now. I'm part of leading a civil society organisation in the UK where we work together with government and the public sector and be really clear about what is the framework we can deliver for ongoing discussions. So we, following a whole range of incidences and a terrible fire we had in 2017, we've developed something called our Voluntary Sector Emergencies Partnership, which is a partnership of 250 civil society organisations, which when there is an emergency that we respond with government. So we are really clear that government, they put out fires, they deliver health services, they deliver some of the national risks as you would expect any government to do. But there is so much more in terms of the humanitarian support that we need to bring to people and to be part of that ongoing discussion and dialogue. So those 250 organisations, some are faith-based organisations, most of them are small community organisations who know the vulnerable people in the community and can act and mobilise in those situations. But we work together and we plan before emergencies and risks happen now. What do we all need to do? Who plays which role? And what training do we need at national and local level? And make sure that those relationships and partnerships at local and national level already exist. And I think this work has been enhanced by, I think, learnings from our government that now is much more open around what the risks are nationally and how it can work together with civil society, that it's not just a case that government needs to transmit and give instructions. That doesn't work. There's very few instances that will work, and it's more about a partnership, a framework, and how they can work with organisations, with communities, and have that ongoing dialogue. So I think there's lessons for government, but civil society organisations play a huge role in linking government and community, and I think we should continue to do that moving forward.
First of all, let me apologize, really. Of course, I did not mean to call and Lisa. I'm really, really sorry. So, great examples. So maybe I can have one follow-up question on some of the challenges you face and what were the means to overcome, particularly convincing the decision makers in working with that civil society and the local communities and empowering them.
Yes, and it's a really good question. And there has been some differences in how organisations work, and governments, of course, are steeped in tradition in how they respond to emergencies. And in the UK, there is a public act and law called the Civil Contingencies Act, which is very much based on command control, that you would see a police force, an army working on. And when you have ongoing emergencies, of course, that doesn't work. When you have to engage huge communities, that command control methodology doesn't work, and we have to temper that. Times when there does need to be some national action, that's a very small amount of times. Tempering that with a real understanding from government about the role of local community organisations, how they work, how they can engage with them, because of course there will be thousands of community organisations in every country. It's not always easy for policymakers and government to interact on a regular basis, which is why we set up the Emergencies Partnership and the framework. So this is about a mutual respect and understanding of how different organisations work, and that real commitment to ongoing partnership to build trust. So that has to be present, and people have to be committed to that.
Great, thank you very much. I'm sure we will turn back to you with more questions also from the audience, but now let me turn to Mohammed, and I would like you please to give us some examples of the governance structures and mechanisms that you were able to establish at the community level, which drive actually the tailored fit-for-purpose actions from your experience in Sierra Leone, and then any other from the 50 years.
Okay, thank you very much. First, let me thank the organizers for inviting me and for selecting this very important, topic of advancing trust, because I think it's, so timely, especially at this time when trust is being eroded, and with the support of the social media, we see how rumors, fly all over the place. And we have to consider certain factors, that influence trust. And for me, in terms of the systems, I think we have to start from the family level, between husband and wife. Is there trust between the husband and the wife in terms of, preparedness, in terms of response, in terms of the way they utilize health services? We know most times as health workers, we talk only to women, in terms of health issues. We leave out the men. So what we do now in Focus 1000 in Sierra Leone is male participation. How do we bring the men in so that they can also support their wives? How do you bring he for she so that these men are there to support, even support their wives, to do breastfeeding exclusive? It's not easy. How do we get men to go out and take their children for vaccination? Even the grandparents, how do you bring the grandfathers in? Because otherwise, you have conflict at home. We saw what happened during family planning when we spoke only to the women. They would want to use the services, but their men would say no. So there was always a conflict, and the men were always suspicious. So what we are doing now is to bring the men on board. Get posters with men taking their children for vaccination. I think that is the starting point. The second point is at the community level, between the health services and the community leaders. They are chiefs. They are religious leaders, traditional healers. And we find out that most times when people don't want to accept positive behavior, they hide behind religion and tradition. So what we are doing now is to bring out the religious leaders, for them to check the Bible and the Quran and identify relevant verses to support the public health messages. For example, during Ebola, when they were saying, we have to wash our dead bodies, because if we don't, they will not go to heaven. So we got the religious leaders to come out and say, under normal circumstances, you are supposed to wash dead bodies. But in an emergency, the Prophet Muhammad, peace be upon him, was able to bury his own disciples and family members during war situations, and they were not buried, and they were not washed. We also saw from the Bible that, if there is an outbreak, people were put under quarantine. Both the Bible and the Quran supports hand washing. So there are a lot of things we can learn from the scriptures, and we are using it positively. We have these religious leaders now, they are in the forefront, they are the champions, of promoting public health messages. And that has also brought unity between Islam and Christianity. We have the pastors and the imams going together in the same vehicle. It has promoted, religious tolerance. But we did not stop there. We brought in traditional healers. Because under normal circumstances, religious leaders don't even want to work with traditional healers. Because they believe traditional healers, they are dealing with the devil. So now, we got them to come in. Because instead of seeing traditional healers as part of the problem, we saw them as part of the solution. And believe me, when we brought in over 10,000 traditional healers, they were able to do mass mobilization. They passed bylaws preventing herbalists from treating people who suffered from Ebola and COVID. So they made a big impact. Market women, very powerful. We brought in over 4,000 market women, because they are in the market. Even politicians know that if the market women are against you, it's very difficult for you to win the politics. So definitely we brought in market women, and they made a big impact. Over 200 civil society organizations. And lastly, the media, including, social media, the bloggers, brought them in, challenged them that information is power. But then, information is supposed to save lives. But when you send wrong information, When you misinform the population, you will be responsible for destroying lives. Which one do you want? To save lives or to destroy life? So we challenge them, and we are all working together now in this big network of over 10,000 traditional healers, 6,000 religious leaders, 200 civil society, over 80 media practitioners. So that is making a big impact. At the next level is at the facility level, the quality of care. When you tell people to go to the health facilities, the health system should be responsive. The quality should be good. If the quality is not good, then people will not trust it anymore. That affects their continuous use of those services if they are not happy with the experience they get when they go to the facilities. So we are also challenging the Ministry of Health now to make sure that the quality of care is improved. Then from there you come now to the next level of the government, the health sector. For too long, I think, we have made health the responsibility of the Ministry of Health alone. But it cannot be. Health is bigger than the Ministry of Health. The intersectorial collaboration, especially now we are talking about zoonotic infections. How do you bring in other ministries? Ministry of Agriculture, for example, local governments, education, social welfare. How do you bring all of them to work together in responding to epidemics? I think that is also working well. We now have the One Health approach, which I think is going very well. The policymakers, we've seen politicians playing politics with health. I think that is terrible. So how do we challenge them? To be, even if you are irrespective of your political party and affiliation, when there is an epidemic, you should speak with one voice. And politicians, and the policymakers, parliamentarians should also allocate resources to the Ministry of Health, so that they will be able to strengthen the capacity of the health workers. We are seeing that's going on very well. We are challenging them as civil society organizations. But lastly, the media. I tell you, health professionals are scared of the media. When you tell them that the journalists want to say, oh, I'm very busy. But let me tell you something. If you don't talk to the media, they would go out and get the information. And most times they will get the wrong information and use it against you. So what I think we need to do is, not everyone will be talking to the media, of course, but in our departments, we should have spokespersons who are ready to respond to the media. We cannot avoid the media, especially now that we have the social media. So I think we need to see how we can look at this system from the family level to the community, to the health system, and up to the national and the media. And last thing I want to emphasize is that, usually we see community engagement as the spare tire in a vehicle. We should not see it as that. It should be one of those 4 tires, if not the steering wheel. So it's not only when we have a problem that we now say, oh, we need to engage the communities. No, we should engage the communities even before we have the epidemics, so that they believe in us, they trust in us. Thank you very much.
Wonderful. Wonderful. Just a quick follow-up question. How do you see the challenge of sustaining that network and mechanism and systems? I think that's the critical element.
Exactly. And I think that's a very important question. How do you sustain? Because I was saying, even here, we have this big summit. We would come for these few days, we'd get a lot of information, and so what? But what we have done in Sierra Leone now is to make sure that we work with this network, not only in an emergency. We work with them to promote regular things like breastfeeding, immunization, blood donation, antenatal care, and we feed back information to them. Most times when we work with this network, we go and request support from the chiefs or the religious leaders when we have a problem to do our campaign. How many of us go back and give them information and tell them, say, thank you very much. Your support made a difference. So we are going back to those religious leaders, back to those chiefs, and giving them information about how the campaigns are moving. Sharing the success stories with them so they feel part of it. So now, the religious leaders are part of the district health management teams. They go to those meetings. It's not only sitting down, no. not only doing their campaigns in mosques and churches, but they are now part of the health system, and they feel very proud about it.
Wonderful, wonderful. Actually, it is in action. Now we have about 7 minutes, and I'd like to thank the panelists for sharing your wonderful experiences, extremely important in setting the scene. And now open the floor to any other questions. Please introduce yourself shortly, and please keep short so we could get as many questions as possible.
Hi, my name is Koen Blot. I work at the National Public Health Institute of Belgium, and I'm head of infectious diseases epidemiology. I'm working on developing myself to become a spokesperson during peacetime, but also during health emergencies in case of a new epidemic in Belgium. We, as a public health institute, don't necessarily have a lot of strong immediate ties to the community. So one of the tools that is a bit more readily available is the media. And so my question is, in fulfilling that role as risk communicator, for instance, how do you see the utilization, the correct utilization of the media and their role and how we use them versus communities? Taking, for example, the pandemic of Mpox in 2022 was a very specific community that was affected. And you want to avoid stigmatization, for instance, through use of the media in a laissez-faire manner. And so I was wondering, how do you see the role of engagement with the media or communities, depending on the situation and what you want to achieve? Thank you.
Thank you very much. And I will take one more question or comment. And
hello, my name is Frode Forlan. I'm working for Africa CDC. So I'll first use one example from Africa. And that is this huge mistrust that was built during COVID from the north towards the south. So I think there was there is a deep cleft still left behind after the COVID. And the accumulation of vaccines in the north with no access to vaccines in the south. The same happened during the startup of Mpox. Those vaccines were fully available in the north. They were not where they were needed in DRC and in the countries in Africa. So I think something very drastically has to change when it comes to also taking responsibility for the biggest challenges and building trust in the countries of South from the North and from the big funders. They are all seated in London, in New York, in Oslo even. These big institutions are in the North talking about the problems of the South. That's the first example of distrust. Another example is with my Norwegian hat. I'm a Norwegian myself and working for the Norwegian Institute of Public Health. And during COVID, I was one of the press spokesmen actually for Norway. But what we saw in all the evaluations after COVID was that one of the main features that made Scandinavian countries come out pretty well was the trust of the government, which very much compared to other countries in the southern European area or in the other side of the big ocean, they were not really trusting their governments in the same way. So I think just like responding to what you're saying, from the local communities to the highest level, people trusted the governments. And that was very, very, I think, important related to also dealing with the pandemic during that crisis. Thanks.
thank you very much for raising the global equity and solidarity, which is a critical element. And then the communication in terms of with media and bringing the communities and national level together. Would you like to give some examples?
Well, I know, as health professionals, usually we are so scared, They say there is a journalist out there. You say, oh, tell him I'm busy. They will be able to get the information, and most times, unfortunately, they may get the wrong information. So what do? We work with the media, and we bring trusted voices on radio and television. We bring religious leaders to talk about their experiences on radio and television. We bring market women. We bring, traditional healers to talk about their own experiences. And the media likes it because they like the stories. They like, positive stories. And let me tell you, one experience we have is that, the messenger is very important. The messenger is as important, if not even more important, than the message. But in communication, we spend so much, you know, on the 3 M's: the message, the material, the medium. I want to add one more M: the messenger. The messenger is more important than, at times, the message. Thank you.
So yes, just a couple of points to add. I think that the point about the messenger is absolutely critical. It has to be a trusted messenger, and sometimes that is a local person, somebody you've known for a period of time. Sometimes it's government. So we've got to test out new ways here, and we know that social media, video, all of those things are really critical. The things that we're testing out, we've just got a new relationship with YouTube. It's really important for the Red Cross and Red Crescent societies. We've taught first aid for 150 years, so we've got a partnership with YouTube to make sure that information is available to people when they need it in a way that's meaningful to them. So it will be a combination of video, of media messages, of face-to-face, which we shouldn't forget, because actually that's very impactful for people. But we've got to test out every way, and the common messaging and agreeing common messages is absolutely critical as part of that. But lots of work to do, because we know the level of disinformation that's out there, and some of the things that we need to tackle in future is how we engage particularly young people in getting those messages across, because they are we all receive disinformation, but I think young people receive the most disinformation, and we need to make sure we have engaged, active participants managing their own care, supporting themselves, but supporting their communities as well, and humanitarians of the future. So engaging young people in that will be absolutely critical.
Wonderful. Let's go through the second round. I think we have time for 2 more questions. Yes, please. Or maybe one. We will check.
My name is Agre Aluso. I work with Pandemic Action Network and Resilience Action Network Africa. So great interventions already, but I just wanted to point one important thing, and thanks, Mohammed, for your intervention. I think you've spot on all of them. So one thing that I've noted, I come from Kenya, Eastern Africa, and around us, of course, even within Kenya, we've had lots of outbreaks. And one thing that has always been a struggle, particularly during COVID, that's where most of these lessons came to the surface. The public health communication, a lot of times are premised on a lot of assumptions that communities didn't have their way of communicating issues before this modern medicine came. And therefore we get into a necessary struggle trying to explain things that communities had ways of actually managing. I remember stories from my own grandmother how, smallpox, in our local language, they had a way. When there was an outbreak, there's a way the people had a code and they knew how to behave and just support those who are impacted, but those who are not impacted yet would move to a safe region, and they have a way of supporting them. Maybe how we do it is different, but it's the same communication. It's the same language they used to use in their traditional indigenous ways. But when we bring it with different language and different directives, mostly top-down directives from government, then it creates a negative connotation. So we really just have to find ways of contextualizing this information, utilizing the indigenous knowledge, so that it's building upon, not creating impression of like we're doing something totally different that has never been done before, both religiously and culturally. The other thing that I really want to thank the Africa CDC colleague is about equity. I think equity and solidarity are things that really build trust, and how we behave in different iterations of outbreaks either build it, eventually when the commodities that were supposed to help reach after many, many months when people could have died, then people would find it difficult to believe that this is really for us. The acceptance of that countermeasure really depend on how it is given when people are in need, and that's something that needs to be changed. And then the other thing that I've also seen is accountability. When COVID struck, there were so many cases of lack of accountability and corruption and mismanagement of resources. In Africa, when an outbreak occurs nowadays, they think government is making it up so that they can attract foreign funding and steal the money. So it's actually something that really, really need to be worked on alongside any other thing, so that citizens can trust that we are not manufacturing diseases so that we attract foreign funding and squander the money. Thank you.
Wonderful. I will have one more very short interaction. Please, you.
Global Health. I've certainly learned a lot more about community engagement in Africa than I've ever learned from the communities in European countries, I have to say. So thank you, Mohammed, for also pointing out this issue with the fifth wheel on the car. Because I think until we have a system where it is part of a grant and part of a funding mechanism to give a proportion of what we think is important to the communities and let them also have some ownership over that, I think we're stuck, and it will remain a wheel at the back of the car. And I'd really like to encourage funders and organizations to not just put it as a small bracket there, but to oblige us to implement this with people in a much more interdisciplinary way, like we do, for example, in medicine. Thank you.
Unfortunately, we are running out of time, but I'd like to ask my panelists if there's any final words, very short.
Community engagement is not a one-off thing.
Yeah.
It's a process. It has to continue. It has to be given, the message has to be given in different ways by different people, in different approaches so that it can resonate. Thank you very much.
And just a final comment from me. I completely agree around making sure that community engagement is permanent, it's funded, because we all know that sometimes there's patchy funding. When there's an emergency, there is 6 months or 12 months, and then we don't see it again. This is an ongoing work to make sure we can build resilience and have those embedded structures within our community. And I suppose the final point around that interrelated impact, of course, we know that health and the society and economics, they're all part of the person's experience. So when we respond to emergencies, we will, of course, think of health, but we really must strengthen and broaden our responses to thinking about their people's livelihoods and their society and their connections as well.
Thank you so much, and I would request an applause to the panelists. And thanks to you all for your interventions. And we have to act now, and we have to act together. So there's a lot to be done, and we are ready to work all together. Thanks. Back to you, Sarah.
Thank you, everybody. Excellent panel. I mean, I can't summarize all that rich discussion, but just a couple of words of things that came out, just as recognizing the complexity of building trust, the pointing out that it requires consistency over time. It impacts different communities in different ways, and it's very strongly impacted by inequity. And I really like the idea of we can't start at the community, we really need to be starting at the family level and building that up. We need to be challenging misinformation, working with the media, whether we like it or not. I think that was a really strong point that came out. And Mohammed, I've heard you say this before, and I think it's really important to emphasize the idea of sometimes working with colleagues that we might see as problems are actually the solutions. So the idea of working with traditional leaders, working with religious leaders that might be a little bit less comfortable with the public health community, really a lot of the solutions sit with them. So thank you so much. And with that, we're going to transition into our next group with the policymakers. And if I can introduce Dr. Carla Vazzotti, who will be sharing her perspectives as well as moderating this session. She is the former Minister of Health of Argentina and is currently the director of the Innovation Hub for Health and Equity Policies at the San Martin National University and a close friend of WHO and the Hub, so we're thrilled to have you. She was in charge of the National Directorate for Vaccine Preventable Diseases Control in the Ministry of Health of Argentina for over 10 years and has been actively involved in various national and global initiatives to improve immunization practices. So welcome. I would also like to introduce Dr. Gregory Emery, who is appointed the Director General of Health in France in 2023. So he is, we're really pleased to have you. He previously serves as the Deputy Director General of Health, where he managed healthcare quality, health economic policies, and advised on international health security and digital health. He began his career with the General Directorate of Healthcare Provision with a focus on healthcare policies, and has also served in the High Authority of Health, which sounds extremely important, where he oversaw the evaluation of medical devices and innovation to enhance emerging technologies. So welcome. And our last but not least, I feel like we just summoned you out of the stratosphere, Dr. Eduardo Gudo, who has had a long trip here, and we're really thrilled that he's joining us. He is the Director General of the National Institute of Health in Mozambique. He served for over 20 years in public health and previously served as the Deputy Director General and Scientific Director of the Institute. Dr. Gudus chairs the Advisory and Technical Council of Africa CDC and serves on many executive committees, including the Lancet Commission for Sustainable Healthcare and the International Association of National Public Health Institutes. So over to you.
Many thanks, Sarah. Eduardo, we are happy you made it. Thank you for your effort, and Gregory, it's great to share this roundtable, and I'm really delighted to be here. I really want to thank Sarah, Chikwe, Josefina, and all they have to have this initiative for this experiment. I think it's extremely important to have the multi-sectoral and multi-dimensional talks, because if we will have the private sector, the public sector, the civil society, decision makers, donors, and with the women and youth perspective, I think that all together, and this discussion looking the same dimension from different points of view is really, really, really important. And as Heidi said, as in a very comprehensive introduction, and it has been said also, the trust is very dynamic. You have to build trust, and you have to sustain trust between crises. And this is a very, very challenging work, and most of us, no matter our positions, we are not trained to do that. And during the crisis, it's much more difficult. And I really think that if we can have this round, it could be interesting. About the first question, it's my first time being a moderator and a speaker, so I will ask the question, and then I will try to complement, not to repeat the same question. But first of all, for all of us, maybe a first round regarding learning past experiences during the pandemic, reflecting on past health emergencies. What key lessons can you share about the role of trust in shaping successful responses, and how can this lesson inform current and future policymakers' practices to enhance collaborating and community engagement? So Gregory, you can start.
I will start. Thank you, everyone. To answer, I will make short response, and we will share a few words after that. First, I will share with you my experience. I worked with two ministers, one prime minister, and in France we changed a lot of governments during these 2 years, and I give each time the same advice. The first one is, for you maybe it's easy to understand, but for a new minister it's not easy. You will have to share the power. It's, I think, very important, because when you become a minister, there is a question of power. If you want to share the power, you have to trust yourself, because you cannot build a trust relation with other stakeholders if you don't trust yourself. And if you want to trust yourself, you have to work a lot. It's an evidence, but it's easier to say, because in a lot of countries, the Minister of Health is not like you, for example, but specialized in infectious disease or in public health. And I think that for politicians, it's not easy to explain what could be the next crisis. And that's my last advice. You have to accept the reality. And the reality is today hard, because we are facing a new era of crisis. And when you start your position as a new minister, since the day one, you have to prepare. You have to prepare yourself. You have to prepare also the relation with the citizens first, the stakeholders, and you have to create a strong relation. And you have to base it on maybe 3 pillars. The first one is transparency, and maybe I will develop later, because transparency, it's for me very difficult, because I will share also, I work every day with media. And during the COVID-19 pandemic, or during the Mpox pandemics, or also in the cholera in Mayotte, I have maybe 10 or 100 questions per day about what are the level of the stock. And as it's a national security answer, I couldn't answer at this question. And it's very difficult to explain to a population that for national security reason, you cannot be transparent. Even if every day you say, I will be transparent, I will make all the transparency, but the fact is that to be transparency, you have to trust yourself. So maybe it's the first part of my answer.
Really interesting, thank you. Eduardo?
Yeah. Can you hear me? Yeah. It's good morning still. I'm confusing on the time, so apologize. You have seen that I'm confused. So I apologize if there is any confusion in my statements. So I just arrived, but I wanted to make it. First, I would like to thank you, the organizers of this session, for inviting me, Sarah and Chico, for that. That is a hot topic. So COVID has been the best lesson that we had on that topic, because we have done many wrong things during COVID in terms of trust. So border was closed, people were not willing to be vaccinated, and so on. And then on the first part of your question, I got to give the example of Mozambique. So I am the director, as you have said. And then we had one of the most highest coverage of COVID vaccine. And the reason of that is not because what we did during COVID, is what we did before COVID. So that is important. I will come back to that point of what we do before the crisis. Because mostly in Africa, so people, they are well known about vaccines. So people, they are willing to get vaccinated. So vaccination is something that is very trustable. And during COVID, so what happened is that because of lack of trust, we made wrong decisions, and people did not trust on our decisions. Well, in terms of the lesson learned, in terms of trust, so I would say that first, I have seen before that trust is a permanent work. It's like in our marriage. If you want to keep your marriage, you have to keep the trust between both of you for a long time. The marriage that lasts for long is not because of the love. Believe me, it's because of the trust. At some time, the love ends. And what keeps there in the marriage, obviously, is your kids, but is the respect.
Don't make me feel sad, please.
So it's an exercise. It's not an easy exercise. It's a permanent. I listened that before. And then that is to say that you will not build trust during crisis. You have to build that before crisis. Second is regular and open communication. So you should be open in your communication, and you will be honest on your communication. If you don't know anything, tell people that I have doubts, but I am coming before of you to say that we have doubts on X, Y, and Z. People will believe on you. The third is that never do use silence as a strategy. If you don't speak to people, community, society, someone will do for you. And they will do wrongly. So you keep speaking to people and explain. Even if you are not sure on what is ongoing, come to people and say that this is what's ongoing. And reputation. I will not trust in someone that has not a reputation in public health. So trust is strongly related with reputation in public health. So building a strong reputation in public health, institutional reputation, government reputation, it's really key. Evidence-based, people rely on in numbers. We are driven by numbers, by evidence, by sound evidence. So that it's another important component. Involve everyone, it's important. Cultivating trust, it's a complex process. And we are in an evolving world where the people, the young generation, they have been exposed to the social media. And if you don't adapt yourself to the new world, you will get lost. And the others that are more adapted, they will pass the misinformation, the fake news. So it's important that when you think about, when we are working on building trust, that you are being up to date on what is ongoing. So you have to ensure that the strategies that you are using for informing people to building trust are the ones that are up to date. Because people today, they look more, I have said that people look at you know how many people look at their phone per day? Someone knows how many times we look at your phone, you open to see if there is anything per day? 2,000 times in average. Do you think that people see 2,000 times news on any printed news and any formal news? They don't. That means that we have to ensure that we are customized to the new generations. Otherwise, we will become up to date, out of date in terms of how to communicate and how to engage community. The last point, I see that you are looking on your time.
No, I'm looking at my notes. Yeah.
Is we did not have any. So building trust is not something that you have a lesson or a class or a course that tells you what means building trust. We did not have. Maybe in the future, after this meeting, we will be more clear on how to do that. But so far, no. So meaning that we have not been trained on that. So we have to build on our common sense. So the point is, what are the tools that you have to develop into building trust at various levels? I would like just to come to the end of my talk to highlight some of them. One, in terms of emerging preparedness and response. Emerging operation centers. So it's a platform that ensures that different players can come together, but ensure that emerging operation centers are relied on a collaborative approach. If you say that I have the mandate to be the lead of emerging coordination and preparedness in my country, and you not involve anyone, believe me, when you look back, you will be alone. No one will be behind you. Second is collaborative surveillance framework. So I'm not sure if Shikwe is in the room.
No.
Unfortunately, he's in the room. I love the collaborative surveillance framework. It's a framework that not only involves data gathering, but is gathering people. So that is important. Involve people. There is no way that you can build trust in public health if you don't involve people. And collaborative surveillance framework that has been developed by the Berlin Hub is about that. So national health observatories. It's a platform that involves people that collect, generate, and analyze data. So social determinants. So that's why I ask if Chico is in the room. Because there is no way that you can build trust at the multi-sectorial level if you don't address the social determinant. When you say that I'm addressing social determinants and not quantitative data like death disease, and so forth, and you look on the social determinant, you respect that education, income, and traditions, cultural, religion are important in public health. If you don't address those social determinants components, you are not talking about the main topic of this meeting, that is trust. I will trust you if you respect me, if you respect that I have my own religion, I have my own tradition, I have my own knowledge, and anything that you do in terms of emergency preparedness and response, respect that. The last one is health diplomacy. We have to be diplomats in health. You know what are diplomats? Are people that are the ones that ensure that different countries, they are working together on the same vision, strategy, globally. In health, it's the same. We have to be diplomats in health. And then just to come to the end, is a question. Are we talking about trust in public health, or are we talking about public health diplomacy? And thank you.
Great, thank you. Thank you for your comments. Just to make a point in a very specific example in Argentina, maybe matching all the items that you brought. In Argentina, we decided, I started being vice minister for 1 year, and then for the last 3 years of the government, I became the minister. At the beginning, one of the decisions of the government was to communicate. But it's not only talking to media, it's a comprehensive communication strategy, and we are not trained for that, for sure. And in emergency, it's much more difficult. But we communicate, and I was in charge of the communication because I was the technical secretary. So I think that this point was a really good decision because it was a daily report with the epidemiologic data and also with an expert that came every day talking about another issue, so vaccination, violence, reproductive rights, very mental health, youth, to the children. So and then at the end I made the concrete recommendation for the population, even if we don't know. If we didn't know. So we said, this is not known, we are looking for information about that, we think that this is the best recommendation to this day. So I think it was really important to build trust, and it was really, really well seen by the population, and I really, and we also had periodical meetings with the Scientific Journalist Network in Argentina, and they were a key stakeholder to communicate also. But social media, fake news, and media themselves, maybe also with some political interest, there were a huge challenge. And there are like 1 or 2 words that I want to introduce before going to the next question. That is, you cannot build trust without empathy. I think it has been said, but the word was not said. But to build trust, you have to be empathic and to see the other with the diversity and with the needs and with their thoughts and all this thing. And the other thing regarding decision makers is that no country can implement these challenges without an investment. It's really important because the Minister of Economy and the President should decide to have the daily report, to have the community engagement, to have the collaborative surveillance. You need money to invest that. So this also has to be said. And Mohamed, you said that health is bigger than the Minister of Health. For sure, it's bigger, but mainly the Minister of Health and the Ministry of Health before the pandemic were like secondary ministries. And from one day to the other, we turned into the center of the challenge challenge of the emergency. And Minister of Economy asked us what to do, Minister of Production, Minister of Tourism, Sports, presidents. So it was really, really difficult and challenging, and we need this transversal collaboration, because without health you cannot work, study, produce anything. So I think that changed, and we have to keep health in the center of the agenda, but this is all about trust and building trust also between all these stakeholders, because interest may be not the same, maybe contrary, the civil society, private sector, the country, the provinces. So it's also a challenge for the Minister of Health to be in this table and to try to arrive to consensus regarding this interest. But I will go to the second round with two specific questions, one for each, to Gregory from France, regarding innovative approaches. In light of France's experience with recent health emergencies, what innovative approaches have you implemented to build trust between policymakers and the public, and how have these approaches influences in the effectiveness of health communication during the crisis?
I will answer your question, but I forget some topic just at the last question. I think that, but both of you said that the question of trust is not only a question of the health sector, but if we want to explain precisely what are the risks of the next pandemics, we have to improve the level of the scientific culture and the risk culture of all our citizens. That means that you have to improve the level of young children. You have to improve the level of scientific culture of the media, but also of the politician. Because I think that the trust is not only a question between citizens and politicians. It's also a question between citizens, politicians, and also experts. And I think that it's a key issue, because I will give you two examples of question in France during the COVID-19 pandemic, and I will go back to the cholera in Mayotte. During the COVID-19 pandemic, all countries, we had to make some choice. For example, the question is today very easy. Do you need a face mask to protect against COVID or flu? When I see everyone here, I'm not sure of the answer, because nobody has a face mask, even if we have a lot of virus outside. That means that we have to use experts to explain the risk, and after that, every citizen will make his own analysis, his own cultures, his own risk analysis, and he will choose if he will wear or not a face mask. But at the beginning of the pandemic, we said that face mask was not useful because we don't have enough masks for all our citizens. That's true. And after that, it was very difficult to create a trust link on this issue. That means that for me, one of the also pillar of the trust is ethics management. How you can prioritize, what are the criteria, how you can fight against also inequities when you define this kind of criteria. And you have to work on it during a peaceful moment. That's the first point. The second point is, and we learn about the COVID, it's not on our habit, but we have also to speak about positive aspect of life. We have to explain when we act good. For example, this summer in France, we organized the Olympic Games, and it was, I think, for everyone a good moment. But for me, we don't use this period to explain what are precisely the risks, how we manage it, and thanks to the organization, at the end, there were not events, but we worked we work on it, and the success of the Olympic game on the security aspect, but also on the health aspect, were not due to the hazard, but it was due to the preparation, the way we work on it. So that's maybe one of the first example is how you can share the criteria of the risk. The second point is how you share the power. And I will give you an example of the cholera in Mayotte. Unfortunately, Mayotte, which is one of French territory in the Indian Ocean, face up today a cholera epidemics. And we decided to work with the religious leader to explain the population what are the risk, and not only with communication perspective, but we give them also a role in the fight against cholera. That means that they were in charge of diagnosis. They were in charge also to help people, because I think that we couldn't only use communication to fight against an epidemic, but we have also to create a more strategic plan. And if you involve the local communities, the religious leader only for communication, you not share the responsibilities. And I think that for me, it's also very important to share responsibility. If you act good, at the end it will be a global success. And if you make some mistake, you have also to share the responsibility. It's very important.
Thank you. Eduardo, regarding community engagement, given Mozambique's unique challenges in health emergency response, what role do you see community engagement playing in building trust and at the local level? How can lessons from community-driven initiatives enhance national policies or emergency preparedness?
We have pharmaceutical solutions and non-pharmaceutical solutions. And most of the times, we are more focused on pharmaceutical solutions. I think, in my opinion, this is something that this session should begin to change, that even if you have the best pharmaceutical solution, you will not be able to get the best public health interventions. We developed the vaccines for COVID, and there are countries that, there are communities that they were not willing to be vaccinated. So that is to say that in many instances, the non-pharmaceutical solutions, they might be, people might be against my opinion, but in many situations, the non-pharmaceutical solution, which is related with this conversation, that is trust of communities, they might work better than pharmaceutical solutions. So pharmaceutical solutions are the vaccines and treatments, and non-pharmaceutical are community engagement. Are we willing to pay thousands, millions, and billions of dollars for vaccine and treatments because we miss the opportunities to invest in community engagement, that we could save money to other priorities because we lost the opportunities to engage people on non-pharmaceutical interventions? So that is the point in myself. So is that pharmaceutical solutions are part of the solutions, but that they are not main solution. The main solution is community engagement. If you prevent people, if you ensure people they can stick to the prevention strategy, we don't need to invest so much on that. If you say people, wash your hands. So So isolate when you are in sick. If you are contact person, do quarantine, and so forth. We will save, we will control the disease, and maybe in many instances we will not need to invest millions and billions of dollars on that. So that is important. That is to me to say that, in my opinion, the future of public health should be on the community engagement. So if you look at many of the preparedness and response plan, if you look at the budget side, what is the budget that is assigned to the pharmaceutical solutions and not pharmaceutical solutions? You will see that most will go under the pharmaceutical solutions. So if we invest more on non-pharmaceutical, so it's community engagement, it's trust, we will not save that. So community leadership and engagement, it's a component that it's important, that oftentimes we put that behind. That communities, they have their own solutions. If you speak with communities, they will tell you what solution they have used for that. I know that the time is tight.
Now, yes.
Yeah, no, I know very well. And then maybe the last one is on the rapid development and evolution on the social networking. This is something that we will not take in account. Based on the experience in Mozambique, most of the fake news that got our work in terms of ensuring that public health measures during COVID were being followed as the government has been determined, is because of the fake news that has been spread to the social media. So that means that the community engagement strategy, they have to ensure that they are updated in terms of what are the new developments in terms of the technology and communication tools. So if I will just tell you, just to finalize, I have an example, so just one to just to finalize. I went to a country and then to do an evaluation on a program. I will not tell you because of law of interest. And then we have seen that they have invested too much on the leaflets, pamphlets, that kind of traditional tools that we have been using. And I did ask, how many people, younger generation, they use those kind of looking at the leaflets, pamphlets, as strategy for education of themselves on the prevention and on a disease. And most of the people say that in this country, most of the people, they look at the Facebook, on the Instagram. So my question is, if we continue to use
this
the traditional and old-fashioned manners of doing community engagement and education, so people in very far rural areas in Africa, in many countries, in Asia, they have cell phones. They have access to Facebook. They have access to Instagram. They have access. So I have no access to those means. So that means I have no idea what's going there. But just to say that when we are speaking about, just to finalize on the community engagement, so in many instances, we are using the old-fashioned models of community engagement.
Okay.
If we don't get up to date to the new models, we will get lost in terms of how to engage communities on that.
Thank you.
Over.
Thank you, Eduardo. We have some points, but we ran out of time, but I think they have been already covered. Role of the media, sustaining preparedness, community protection, multi-stakeholder engagement. I think that they have been covered. Just one point. I don't know if we have time for questions.
We don't.
No. Just one last point that is not going to be developed, but in English you have the word policies and politics. In Spanish we have only politica. If we don't make the difference between policies and politics, we will have some problems in the future. So this should be very, very important. And sometimes politicians or people who are in the decision-maker chairs mix these two words, and they have a lot of pressure. So civil society, international agencies should be very care about this difference. So I think it has been a great round. I'm really, really happy to share with you. I really, really thank you, and I give you the floor. Sarah, thank you very much. Sorry for not having questions.
No, no problem at all. Yeah, I just a very quick summary, because I know for the interest of time, there's a lot of excitement around this area. So also, if the speakers can stay around, we'll find chances to speak. I mean, I think we heard a bit of a call to action from the speakers. So just a couple of takeaways as we go back to our the conference, to our jobs. What are some of the tangible things that we can do? And I think we really heard that we can keep adapting, that we need to keep speaking, and that we can't use silence as a strategy. To engage experts, I thought the importance of sharing our power, even the little piece of power that we have, we need to also be sharing. Engaging meaningfully with communities, families, and the media. Always making sure that we're promoting empathy, transparency, and inclusivity in our work. And I thought that really important comment of we need to be also trusting ourselves. So with that, I really want to thank you. Chikwe is very apologetic he wasn't able to be here today, but I want to thank you on behalf of the whole of the WHO Health Emergencies Program, and have a lovely week.